Hello, I'm Professor Leona Konieczna in the Division of Nursing at Capital Community College. With me is Nancy Casey, a clinical faculty member, and together we will be discussing the topic of new nursing graduates' employment in long-term care nursing. Results of surveys from the class of 2009 and 2010 demonstrate a significant shift in employment for new graduates. Prior to 2009, the majority of new graduates were hired directly into acute care in hospitals. The data now shows that more than half of new graduates are being employed directly into long-term care. We will discuss this issue with two graduates from the class of 2010. Welcome to Linda Prell and Paul Back.
Thank you. I'm going to direct the first question to Linda. Linda, can you share with us the process that you use to select the long-term care facility that you currently work in?
Well, I think I was really lucky because I did do a clinical rotation at my current facility, and I think they have the it factor. And when I say the it factor is, it's a feeling that you get the minute you walk in. The residents are happy, they're out of their rooms, both in the long-term setting and in the subacute rehab side. They're happy. If you look at the staff, they're interacting well. They're working together with the CNAs, the doctors, the kitchen staff. They do computer charting, which I have come to find out is a luxury in long-term care. It's all computer charting. They have an excellent reputation in the area. They're one of the tops. They have excellent state surveys. If I did not have the advantage of working there for a clinical rotation, I would definitely look to facilities that do have computer charting. I think that is an advantage. I'd look to see how long the staff has been employed there. In my facility, you know, most of them have been employed for 10+ years, which tells me they're happy, they're respected, they enjoy their jobs. I would walk into a place and see if I'm greeted. Are the patients out of the rooms? Do you see anyone? Because chances are if you don't see anyone, they're maybe still in their rooms. I would also ask questions on, you know, being a new graduate, what do you see? Do you get IVs? You know, do you get wound vacs ever? Do you have G-tubes? Do you have trachs? So you can see what kind of experience you're going to be getting. And proximity is another one. I'm very close, and for me, having children, it's great to know I'm not spending 45 minutes to my facility. That being said, I would travel the 45 minutes if it meant going to a great facility.
Okay. Thanks. How about you, Paul?
I started looking for jobs in acute care, and then as that wasn't panning out, I was moving over to the long-term care facilities. But I also was noting that although acute cares were electronic applications, we were doing everything online, and I just felt that there was too many filters between my application and somebody actually getting to see it. Mm-hmm. So one of the reasons I started going to the long-term care facilities in general was that they're more likely to be taking paper applications, getting a chance to look at my cover letter, and I would get a better opportunity to get an interview. When I started looking, some of it was the location, just sort of going in a wider circle, but also the facility I finally started looking at. I liked their model of care. It was the Plane Tree model. I thought that was important, finding out what their philosophy of care was, what the baseline standards were for how are we going to be operating here. It was interesting when I took tours, how clean it was, how long, as Linda was saying, how long employees have been there. It was interesting to see that there were a couple married couples where I was. They also had an assisted living facility. They have assisted living, long-term care, and rehab there. So there was a variety of experiences I could have. What I was concerned about was the med paths. How many nurses, how many CNAs on each floor? which I found out eventually we have a very good staffing ratio at our facility, having talked to some people who have worked at other facilities. So that was very nice to know as well.
Paul, I'm going to start with you this time. Could you tell me about your orientation, and was there any preceptor experience as a new graduate?
Yes, our orientation, we spent about a day going over policies and such, but then we were already on the floor, and I was assigned to one of the long-term care floors. Actually, another graduate from here was assigned to a different floor. I spent about 6 weeks just on that one floor on one shift, which I thought was great, getting to know one set of patients. In long-term care, you are taking care of a lot of people, so it's much more important to find out who those individuals are, and that helps give you your pattern for your day. But
before you go on, Paul, what's a lot? Can you?
32.
32. Okay, so
32. There's
ahead.
one nurse for 32
one
patients.
nurse for 32 patients.
And we generally have about 4 or 5 CNAs taking care of those same residents. In the rehab side, it's 16 patients per nurse. There's 2 nurses on the floor for 32 patients, and there's still 5 aides for the entire 32. But then after I did 6 weeks, then I moved on one floor. Then I was starting to be put on other floors just to get a general sense of the, each other floor, each other assignment. So because I was hired per diem, I was more likely to be floating around from floor to floor. At this point, I can work on any floor, just not at nights, because I've never been oriented at night before. I also think it's important to make sure you get oriented to a particular floor. It's not just good enough to be oriented to the facility and know how things work in general. You have to have a day or two of getting to know each individual floor and its pattern, because you're relying on your general knowledge of the floor to pattern out your shift.
Okay.
And so if you don't have that, one floor, I was just oriented one day, and it was a lot tougher doing it by myself the next day.
Did you have the same preceptor, or did you rotate among a couple of experienced nurses?
I generally, the preceptor was the person who was generally working that shift.
Okay.
So the floor manager for East 2, the floor manager for East 1.
Okay.
And that's how it went. So it wasn't one person following you to different floors.
Linda, now to you. Tell us about your orientation experience. Was there a preceptor? What was the process?
Well, I was hired originally as per diem as well, and that was a concern of mine as being a new grad. We don't have that experience that others do. And so they reassured me that it would be a great training program, and it was probably 6 to 8 weeks, and I was oriented with one of 3 nurses. And the reason why they do that is they do that because each nurse has their own routine and rhythm and a different way of doing things. Even though you have to accomplish a goal, you have a different way about going about it. So that way I could see, different approaches, and I can pick what works for me, And I was oriented all on the rehab side, which again for our facility is 15 patients per nurse at the most, and it can be a little less. And out of those 3 nurses, and I want to say everybody at the facility, if you have a question, you are encouraged to ask. And even now, everyone who trained me said, I still learn something new every day I come into work. And that definitely is their philosophy. So I did, 6 or 8 weeks on the rehab side, and then they did have me do a shift, 1 rotation on each shift, just so in case I was called in, I would know, kind of what goes on. And then I was given probably 3 days on the long-term side on one of the units, and for us, it can be up to 30 patients per nurse.
Okay.
Big difference. They're not as acute, but you have 30 patients.
Right.
And not only that, but I'm sure Paul will realize is, you know, when you go to the 30 patients and you've never been on the floor before and you're passing medications, I'm looking at all the bracelets. I don't know anybody. Nobody's in their rooms because they're in the day room, they're doing activities. So that really adds a lot of time to find out who the patients are. And then, you know, on long term, you also are dealing with, do they want crushed? Do they get their meds crushed or whole with water, whole in applesauce? There's a lot of variables. Who gets thick and liquid with their pills? And so that was a shorter orientation for me, only because I plan to be more on the rehab side.
Do they have pictures of the residents with the meds? I know where I worked, we had pictures.
They do, however, I never think they look
like the person.
You know, I think the real person is a lot different.
Okay.
So.
Okay, I'd like to start with you again, Linda. Can you talk about, like, for a particular shift where you currently work, how do you set priorities for your shift?
Well, priorities on the rehab side and the long-term side are completely different. So, but I always, like on the rehab side, I always start with listening to report. During the report, I'm going to see, you know, like the cardiac patients, they're a priority. Any respiratory issues, the diabetics. Also, like with the rehab, you know, you have pain management. So if someone needs to be medicated, you have to get right in there. You know, so I'll listen to report, and then I go by what I hear on report on how I'm going to start my day. On the long-term side, which is a lot different, I start my day walking in, and the only thing we do on paper is the flow sheet, which has the vitals, I&O, and glycol stools. And so I'll start that by highlighting what needs to be done on my shift. Then we have a CNA assignment sheet. And if there's certain notes, like if I have a patient who's a high fall risk, I want her in bed by 8 o'clock because that's safer for her. So any notes that I want to make, I write it on the sheet, so that way while I'm listening to report, if the CNAs come on, they can look, they can get the vitals they need, and also any notes that I've made. So after I do that, I listen to my report, and as soon as I'm done report, I count with the nurse, and then I personally make rounds. A lot of nurses do not do this, but for me, it's very important. I try and limit it to 10 minutes. But I go to every room and I peek my head in, say hi, how are you today, see how they're doing. And when I'm doing that, I'm doing any lung assessments, cardiac assessments. The residents that are on G-tubes, I'm looking to see, are they running at the right rate? Is the right bag hung? If not, do I have the right supplies in the room? And again, you know, if something's going on with a patient, you want to know about it when you walk onto the floor versus in the middle of your shift. And so, you know, I'll go through, and of course, if I got in report that, you know, Samantha was having chest pains, I'm going to start with her first. Mm-hmm. But I go, you know, I stop through everybody, and then I also have made up a little worksheet myself that I work the 3 to 11 shift primarily. And so I have a list of who the diabetics are, who the Coumadins are, who has G-tubes, who has IVs, if they're on IV hydration. So that way I know they're my priorities, and I'm checking those things off as I go along, just to kind of keep me, you know, on task. And at any point I can look at my sheet and know exactly where I am.
Paul, what about you as far as setting priorities for your shift?
Priorities are generally getting report from the nurse prior shift. Then I'll give report to we'll sit down with the CNAs that are on, all, you know, myself and the 4 or 5, and we'll give a report to everybody. So that way all the CNAs know what's going on with all the patients, in case the CNA that has that resident will be busy with another. You can still say, I need you to go and check this person, because it needs to be done now, and I'm not worrying about which CNA is doing the job. Then I tend to go through, we work on paper cardexes, and we have two. We have one for the meds, we have one for treatments. I'll quickly go through, I'm now experienced enough to know who's getting the meds in general, but I still have a tough time remembering who's getting what treatment, and those change a little bit more frequently. We're dealing a lot more with taking care of people not getting pressure wounds. So there's a lot of creams involved. There's a couple people on O2 who want to be taking their SATs, but a lot of that stuff happens while I'm doing the med pass. Prioritizing the med pass really centers around insulin and who's going to be on the floor. Otherwise, everybody's stable. But we do have some people, we have a dining room on our floor and we have a dining room off the floor. And about 5 people aren't on the floor. So now you have to start factoring in who's actually going to be on your floor during your med pass.
How do they separate who's who? Is it based on cognitive ability or swallowing concerns or resident preference?
Resident preference for the most part,
Okay.
because either way, whichever dining room they're in, they're probably going to have some aide around to help them if they need anything. They're probably going to be on our floor for dinner if they've got any cognitive problems.
Okay.
But a lot of it's also just mobility, and if they
Okay.
can get themselves around, they can eat in whichever dining room they'd like to.
Okay.
So then I get a med pass done, and that's when anything that I can't do during the med pass I can do. I can do lung sounds during the med pass. I can do, pulse oxes and such. But then treatments such as wound care, I'll do in between my med passes.
Okay.
And then I'll start on the second med pass and then go on. In the morning, the afternoon, for the 7 to 3, you're generally dealing with orders from the doctor. And those tend to come towards the afternoon. So I'll be taking care of a lot of orders in the afternoon, making sure the meds, the Coumadin, for instance, you're going to get your PTINR. I want to make sure that the Coumadin's ordered because the new dose is going to be due that evening at 5. I want to make sure that it's in from the pharmacy.
You both touched on this a little bit, but I'd like to explore it a little bit more. And again, we'll switch to you. Start with you, Paul. I know that when I worked in long-term care, I had a 30-bed unit myself, as well as being the only RN. I had another 150 patients I was in charge of. So the issues of time management and organization are very important. Can you describe a little bit more about how you prioritize or organize your shift?
Because the med passes take so long, you've got 32 patients to give medications to. It can take 3 hours to do, unfortunately. And the way things are timed in long-term care, except for maybe the last hour and a half, you're working on a med pass and everything else has to get fit in. If something happens, you're going to have to, your med pass will sort of go to the side. You have to just remember to get back to it and where you were. I write down a lot. I carry around a roster every day. They're not the detailed lists that we had while we were in clinical of all the different things, but these people are stable for the most part. But you're just writing notes next to each name as you go along. Keeping track of times is really important when we're documenting. We're not just saying, we talked to the doctor about this problem, we got an order. We talked to the doctor at this time. This is when we got the order. This is when the meds came in. This is when we were able to start it.
So
details like-
documentation is just as important.
Yes, it is.
As in
Yes,
acute
it
care.
is, because we really do want a timeline for that care and how quickly we responded to things.
Sometimes, I'm going to interrupt you, sometimes the perception in long-term care is that everybody's a do not resuscitate, so it's no big deal. Is that true?
I would say about half of ours are do not resuscitate.
Okay.
The interesting thing about that is that in long-term care, if you do not resuscitate, you must also have the order, at least for us, of the RN may pronounce.
Okay.
And so I actually had that experience for the first time last Friday. And that's just a part of the job that you don't think about when you're
So
going.
for students that are watching it, when you talk about RN may pronounce, you're talking about the pronouncement of
death.
Of death, right. So you're the
And
one
you're the
that's
one
pronouncing that the person has expired.
You're pronouncing that they're expired. You're filling out the paperwork on the death certificate. It's your name on the death certificate. You're calling the family. You're calling the mortuary. You're doing all this stuff. And I knew it was going to be my time to do it at some point. But that's one of the things you cannot train for in school. And it was very surreal. But overall, not everybody's do not resuscitate.
Okay.
We've had people, go out to the hospital, then they come back. Some people go out to the hospital, they don't come back. But we try keeping them in our facility, but we don't do IVs in our facility, for instance. So anybody who needs that is going to be going out.
Okay.
But most of them are, I'd say about half and half in terms of the
And of course, do not resuscitate does not mean do not treat.
Correct.
Those are two different things. So Linda, you mentioned your worksheet that you have for your patients. Any other advice you would give to students as they look to manage their time or to organize?
One is do what works for you. I was a student who did not do any study groups because that would not have worked for me. So like my worksheet may not work for Paul, and do, you know yourself, and listen to the advice of others, but go with your gut. One time, what I find hard to manage is when, in a perfect world, when everything is going right, it's great. However,
are those times gone?
However, with 30 patients is one problem sets a whole cascade effect.
Right.
Which is
kind of
hard.
what you alluded to.
Yes.
Yeah, right.
So how do you recover?
Well, you definitely, that's when your prioritization comes into play, and if this happens right at the peak of your med pass, well, you have to get the diabetics, you have the cardiac meds. You have to really look to see, well, are they just getting aspirin? If so, well, that's not a priority.
Okay.
You really have to look at the situation. It's hard, and in new orders, I have a hard time, when new orders come up and then somebody's pulse ox is going down, and of course it never happens one at a time.
Right.
Never.
Right.
Three at a time.
Right.
But that's when you do utilize your supervisor and you do call and say,
oh, good point.
this is happening and I need some help. And they're right down to lend that to you.
The supervisor has been very helpful in my situation as well, because they will do the admits, or at least they'll start the admits. But if something extraordinary happens, they'll be up there, and they'll be either more than likely starting the paperwork or whatever needs to be done on the event that's happening. You're going to keep on with your med pass because you're the person who signed for the meds.
Right.
When Linda said, I think Linda mentioned earlier, signing off on the meds, we're talking about you have to sign off on the narcotics, because unlike the Pyxis, we have carts.
Do you still have the locked keys?
We still have the locked keys. So we have the cart is locked, and there's a separate lock for the narcotics, and you have to go in every shift, and you're not counting all the meds, but the narcotics. You're counting exactly how many there are, measuring out the vials to see how much morphine such is there and signing off on it every day. So if you're going to be doing something, you're going to be the one doing the meds because your signature's on that sheet of paper.
And as a new grad, I would think that it's comforting to know that you have a supervisor that you can call and say, listen, I need help right now, and they're going to come and assist you. You're not feeling like you're all alone with this assignment.
Yeah.
Yes. And especially like that is something I really like about the rehab side is that you have another nurse,
Right.
so you can bounce things off, and just like sometimes you want another set of eyes on something.
Right.
And the long-term unit that I do work happens to butt up to the rehab side. So in the event, you know, I can't reach the supervisor right away, or she's delayed, and it's not something that important, but there's an experienced nurse right across the hall. I'll ask her, do you have a moment? Can you just take a peek? This is what I'm thinking, you know, do you feel the same way? And
you mentioned sometimes patients have to go out to the hospital. And what students don't realize is the W-10 form that when patients are in acute care get sent to long-term care, you are filling out the same form for them to go to the hospital, except now you're needing to do it on an urgent basis because if they have a need to go out, they're going to need to go out fairly quickly. So do you have to document on those forms?
Yeah. Once again, sometimes something like that the supervisor might pick up, but we do have to pick it up ourselves as well. Also, it's not just on an emergency basis, it's like for every doctor's appointment.
That's right. That's right.
Oh.
That's right. Yeah.
You're doing a W-10.
Okay.
Generally, the doctor's appointments are handled by the night nurse because from 11 to 7, they're doing more administrative stuff while the patients are sleeping.
Okay.
So one of the things they're going to be doing is if they know there's an appointment the next day, they're the ones filling out the W-10, and then you come on 7 to 3, you're just making sure of the meds the last time they're given.
Right.
That sort of
So that whole continuum of care and medication reconciliation is seamless for the patient as they go from long-term care to hospital and back to long-term care.
Okay. I know that the students right now are learning about delegating, and it's always a challenging role. And I know both of you have talked about working with CNAs, and I want to start with Linda. Can you tell me how you handle delegating, or anything that's worked for you that you could share with the students?
I think that's been the hardest thing for me, actually. Yes, in the rehab side, not really, because they have their routine. They really it's different on the rehab side. On the long-term side, what I found was when I first got there, you know, they've been there for years. You know, this is a great staff. They've been there for years. They know their patients better than you do. They have their routine, and they don't want to change it. And so for the first week, I kind of looked to see, you know, what was going on, and then, like, I work 3 to 11. Well, there's not that many pulse oxes or blood pressures that I need, but there are some vitals I need. I want them done by 4:30 because if something's going on with the patient, I want to know it at the start of the shift when possibly a doctor's still there versus at 8 o'clock. That didn't go over that well.
So how did you handle that?
Well, you know, at first I told them I know things are different. I know, you know, I'm replacing so and so, and it wasn't that important, you know, to her, but this is how I want it done, and I want it done by 4:30 because A, the patients go to the dining room at 4:30. So if you don't get it before 4:30, you're not going to get it until after 6. B, if something's going on with a patient, I can call a doctor now and get it, you know, done. So I told them, and then some of them did it, some of them didn't. So then I highlighted, you know, by 4:30, and then and I reiterated it, and then there was one person who did not, and I said, and this is someone I really respect and think a lot of, which is probably what made it as hard as it was. And I said, you know, I've asked, and if it's not done, then we're going to have to talk to the supervisor because this is what has to be done, you know. And after that, it's always done by 4:30. In fact, they do it right when they get on the shift now. You know, and you find that with so many patients, you can't do it all yourself as much as you would like to, and so you really have to rely on your aides because they'll either make you or they will break you. Mm-hmm. And you also know the aides that are meticulous, that will look them head to toe every night, and if there is a blemish, they are coming to tell you, whereas there's others that look on, you know, the potential skin sites. They'll pay attention to those, but maybe overlook. So you know.
You mean like bony prominences?
Yes.
Right. Okay.
Yes. Yes. Thank you.
All right.
But you know, so you know the aides. You know who has which strength, and because someone is caring, the other person, it's, you know. I still work on the delegation.
Yes.
I find it. I find it hard.
Yes.
How about you, Paul?
Yeah. Working on the long-term care side, I actually find it easier on the long-term care side because of the stability of the patients. And the delegation, it saves me a lot in terms of, like, say, applying hydrophor to a leg, stuff like this. And you say, okay, here it is, and you can put it on. So it saves me a lot of time getting them to do it. I find the best thing in delegating is if you need somebody to do something that's not part of their routine, because I need a vitals on somebody, or I need you to do this. Tell them why. Tell them why. Don't just say, get this for me. Right. Because without knowing why, one, they're not going to feel part of the team.
Right.
Okay.
Right.
Two, they're going to decide on the priority of it, because they're going to say, but I've got Ms. Smith over here, or Mr. Jones over here, that I have to do this. They're not going to know. They're going to make decisions for themselves on what the priority of it is. And frankly, if I have time, I will do things, if I'm right there, that the CNA would normally be doing. Having been a CNA, I remember that's the certified nurse's assistant. The hospital is a PCA, it's a patient care assistant.
Right.
You know, but my attitude is all those CNAs are there to help me do things that I would normally have to do on my own. So nothing that they do is something that I shouldn't be doing.
Okay.
And if somebody needs to be toileted and I'm right in the room, I'll get them on the toilet. And then I'll get the CNA to, you know, eventually get there so I don't have to wait there.
Right.
But I think that they appreciate that I'm not just handing things off all the time, just by doing things when it's all right for me to do it and I'm not in a rush. If I'm in a rush, yeah, I'm going to get the CNA to toilet that person, even though I'm there, because I've got something else I have to do. But then, but they know that I'm there for them if they need the help, just as much as they're there to help me.
So you're setting up the teamwork part of it, so that you're doing things for them, so when you're asking them to do something for you, they feel like there's a lot of give and take there.
Yes.
And also by giving them the explanation, you're treating them as an important team member, not just someone that you're delegating things to.
Exactly. And I also, you know, that way I get a lot more feedback from them too.
True, yeah.
So they don't clam up and just tell me what I'm asking them. Because they're a member of a team, they're going to be coming to me sometimes, you know, 9 o'clock at night, 10 o'clock at night, I'm wishing they weren't because I know that means at least an extra hour before I can go home, but they're going to be telling you these things, and it's very helpful because you don't have enough time to spend with every single patient.
Right.
They are your eyes.
That's right.
Right.
Yeah.
Just like we're the eyes for the doctors, they're the eyes for the nurses.
True.
So Paul, what do you like best about your position as a nurse in long-term care? It's a two-part question.
Okay.
And what would you like to change?
What I like best is having an extended period of time to get to know residents. It's not in the hospital that they're in there for 3 days, then they're gone. And also, that also means that I have to learn a new patient fairly quickly in the hospital too. So I get to know people. Sometimes it's a challenge. You want to keep in long-term care. You're probably a little bit more friendly over the long term, but you really still have to remember that one, these are people you're taking care of. They're not your friends. You wish to be friendly with them, but you don't want to take away the respect that you give to somebody who you think of as a client, as a patient, et cetera, et cetera. And you can find that line going back and forth, and you have to pull yourself. Sometimes, you know, and the same thing happens with the aides, and I can say, okay, that's fine now, but then all of a sudden, when it's like a couple aides together, they're doing the same thing, then it feels like picking on the resident. And so that line you really have to pay attention to. I think what I don't like about it is, I guess I was trained well enough to, I want my med pass done an hour before, an hour after.
Right.
And that's not going to happen in the long-term care facility. The budget's not there for the extra nurse to allow that to happen. Even though, you know, because if that changed in some way, sometimes it's just useful to have a couple med times switched, so you can sort of give yourself a legitimate 3-hour med pass if you have, you know, not everybody at 5 o'clock. You know, some people are at 6 o'clock and that sort of thing. But if you had a little bit more structure there, then the crises that come along won't feel like a personal affront. It's like, you're keeping me for another 2 hours because this happened.
Right.
Or, you know, my med pass is stretched out for that long because this happened. The staffing would fix that. But
and I found in long-term care, residents were on 14, if you work the day shift, 14, 16 medications. Are you seeing that?
Yeah. There's about 3 or 4 that are like that. But everybody is particular. Lots of crushes.
Lots of crushing, yes.
And you'd be amazed at how much the little things take up your time. Because on a paper MAR, how many times can you write your initials? You know, how long does it take and go through that sheet? And you think, oh, it doesn't, you know, it takes me a second to write my initial. But when you're doing it over and over and over again, that's a large part of your med pass. Crushing meds, it's a large part of your med pass. You're not crushing, you know, the 15 all at once. You're having to crush, you know, 2 or 3 together.
Well, we're happy that you're doing it the right way.
Yeah. So that takes a long time.
Linda, what do you like best? And what one thing would you change?
I love the residents. When I started nursing, I wanted to go into it for oncology or hospice, which the facility I do have has a whole hospice program, which eventually I may get into. But I never really looked at long-term care. And for those like Paul that want to get to know the patients and the families, and I love it. I love getting to know them, and I love learning, you know, who they are, who they were. Love it, love it, love it. And what would I change? I would change by just having more time, you know, whether it be the med pass, but, you know, it's hard because sometimes those residents are sad for whatever reason, and you sit down and you hold their hand and you let them talk, but you can only do it for so long, and then you have to get to your med pass. And so that's when I find it hard, and that's what I'd like to change is just having more time.
Yeah, that's a resource we really can't have a little control over.
But you know, I actually, to kind of give that, I know the residents like animals, and so for me personally, like on the weekends, I'm bringing my dog in, and I'm just going room to room and letting him have that pet for a minute, and I get that extra piece myself.
That's great.
A lot of people won't do that, but
that's great.
Contact with the family is important too, and you'll get that more in long-term care. Both because it's long-term, you're going to have the resident for a long time, but also because there's a lot of dementia, they're not the ones making the decisions. In the hospital, many more competent people, you just have to talk to them to get permission, or we're going to tell you we're going to be doing this, and they're the only ones that need to be notified. Long-term care, you're talking to the family a lot, because even though, you know, every bruise, you're trying to update the family. Every scratch, you're updating the family. You're constantly in contact with the family then. And so you get to know the families as well as
you're seeing a lot more family involvement than you would have in acute care.
Not only that, like when you have a new patient is, you know, was this their baseline? And you're talking to them, and you're seeing subtle little things, and you're talking to the families. Is this new? Has this been going on? And it's very important.
I just have one last question. I'll start with you, Linda. In your opinion, how has the perception of the long-term care nurse changed?
I think it continues to change. I think in a lot of ways, people have felt that long-term nursing is not real nursing and that they're med card nurses. I disagree with that. I think that as the patients coming in, because they are becoming more acute, and like we're seeing more IVs, you know, we're seeing additional things, is I think the better we do at our jobs and the more assessments and the more responsibility and the more we appreciate our own positions, we're going to change that perception one patient at a time.
Paul, did you have something to add to that?
I think that from what I've heard, because I've only been doing it for 6 months, but the nurses that have been there for 10 years, 15 years are saying about half of their job they weren't doing when they started. It's a different job from 15 years ago. The long-term care, they were very stable. You weren't worrying about, really it's the dementia that they'll mention the most. That there's a lot more dementia care, a lot more increased restlessness, so you're giving out your Ativans and such, and Xanax a lot more. And that's something to watch out for too, is remember to give the Xanax, give the Ativan, the narcotics and the other PRNs for increased agitation when it's the patient's baseline, the change from the patient's baseline, not because you're trying to get through your med pass. And this person over here keeps on taking off their alarm belt. That's not, if that's what they normally do, that's their baseline. You've got to deal with that. But if they're acting beyond their baseline, that's when you're giving it that PRN, because it's not there to make your job easier, it's to make them more comfortable.
I think that all in all, from what I've seen over the years, is that the quality of life for residents has definitely improved, and it's been good nursing care that's been a part of increasing that quality of life. I want to thank you, Linda and Paul, for sharing your experiences today. This information will be helpful to our graduating students in considering nursing careers in non-acute settings. For Capital Community College, I'm Professor Leona Konieczny with clinical instructor Nancy Casey. Thank you for watching.